Okay, so this is chapter 25. We're going to talk about drugs for fluid balance, electrolyte, and acid and base disorders. So first we're going to go through a quick review of fluid distribution in the body, osmolality, tonicity, osmosis, those kinds of things. And then we'll talk about IV treatments, which are going to be either crystalloid or colloid. And then we're going to cover a couple of electrolyte disorders, mainly sodium and potassium, and then acid-base disorders. Okay. So, body fluid compartments. So the thing to remember here is that when you give an IV treatment, that you can put in like think of a saline solution, 0.9% saline. You put in fluid and you put in salt. And really, if you're putting in an isotonic solution, you're trying to match the general concentration of what's inside the vessel. But remember, those fluids, especially water, water is just going to go where there is a higher concentration of solutes or particles. So water is able to move between just the vessel and this interstitial fluid, and it can move into the cell, or it can move out of the cell and back into the blood. So so that movement, so putting things in, and I mean, I think we kind of realize that. But ions and large molecules like proteins or starches, a lot of times, we'll see that when we talk about the colloid IV fluids, those aren't able to move as easily. Now ions can move because there are channels and there are pumps and stuff that put them where they're needed, but they have to go through those channels. They're not able to move as freely as water is. So that's kind of why we want to match the osmolality, or tonicity. Okay, so controlling water balance is essential for homeostasis, obviously. Frequent indications for IV therapy include imbalances of body fluids, so like dehydration or fluid loss from burns or hemorrhage or something like that. Electrolytes, acids, and bases. We're going to cover those things. So as quickly as I can here, the difference between osmolality and tonicity. So we've been hearing about this stuff for, well, probably since biology, physiology. So osmolality is an actual lab value. So we can actually give a concentration and we can say that the concentration is usually between 275 and 295 milliosmoles per, I think that should be liter, milliosmoles per liter, or milliosmolar. So that's what osmolality is. You can actually measure that, the blood concentration of particles dissolved in the blood. The greatest contributor is sodium, so we'll see that later when we cover hypo and hypernatremia issues. Tonicity is different from osmolality only because tonicity is a relative concentration. You don't really even have to know the osmolality to be able to have a tonicity type of effect. It just all that matters with tonicity is that there are more or fewer particles on one side than there are on the other, regardless of what the osmolality is. Now, usually because we're talking about the body, it's generally within this range, unless you're dehydrated or some other kind of issue. But that's it. So when we give an IV solution that is isotonic, what we're trying to do is we're trying to match these values, these normal values. Now the blood may not be within those ranges, but we still call it isotonic because we're trying to match those values. So that can actually affect, depending on if somebody has high blood pressure, low blood pressure, what their blood osmolality is, could affect which IV treatments we tend to use. Okay, because if they have hypertonic blood, then we may want to put in a hypertonic dextrose solution or something like that. Okay, so osmosis. Osmosis is just that movement that we're talking about. So if osmosis is a movement of water from a low concentration or something that's very dilute to an area where there are more particles, or a hypertonic area. so to where there are more particles. So isotonic means that you've matched the concentration pretty much. So there's no net flow. Things are kind of wandering back and forth. Water's kind of moving back and forth, but no net change. Hypertonic, if it's a hypertonic solution, that's going to draw fluid in. So if we're talking about the inside of a vessel and we put a hypertonic solution directly into a vein, into a vessel, then that's going to pull fluid from the interstitial space into the vessel. Now the opposite will happen if we put a hypotonic solution in. A hypotonic solution, while it's giving more fluid, but that fluid will more easily move to the interstitial space. Okay. Okay, so fluid balance disorders, most important regulator of fluid intake is thirst. We get thirsty, we drink, and that's what's keeping us, preventing us from dehydrating. So primary regulators of fluid output, we've talked a lot about this too. So obviously are the kidneys. The kidneys are what is kind of controlling that. It's deciding, okay, is the osmolality, is the fluid volume high or low? And then they can sort of adjust to either cause you to excrete more fluid or electrolytes, or reabsorb and maintain those fluids. So it does this primarily through the renin-angiotensin, the RAA system, renin-angiotensin-aldosterone system, and aldosterone activates sodium-potassium pumps, which causes you to reabsorb sodium and secrete potassium, and then of course the water will follow that sodium, and sodium and chloride. See, that's the thing, is chloride also goes. So you've got more molecules leaving than going back into the nephron, and so you end up with more water that's leaving as well. Okay, so antidiuretic hormone just puts what are called aquaporins and allows water to leave the nephron and go back into the body. Okay, so deficient fluid balance disorders can cause dehydration or circulatory shock. If you don't have enough fluid, you don't have enough pressure inside your vessels, and they can essentially collapse. At least you're not going to have enough perfusion to perfuse the organs if you don't have enough blood fluid in the vessels themselves. Okay, so we can treat those with oral fluids, depending on how severe it is or how urgent it is, or IV fluids, and you can put the fluids directly back into the body. And sometimes we even want to add colloids to it to pull the blood in, or pull the fluid into the vessel, so the blood vessels can expand and actually increase more pressure to increase that flow to get the blood to the organs, if that's what has to happen. Okay, so excess fluid balance disorders, we kind of covered that in renal, and that you can just use diuretics primarily for when there's excess fluid. So mainly we're thinking about either not enough fluid, or the BP, the blood pressure is just too low. Okay. So IV fluid therapy replaces fluids and electrolytes, and we're going to talk about two different categories, crystalloids and colloids. And usually the cause of water and electrolyte loss in general, I mean besides just not drinking enough and getting dehydrated in that way, but the actual loss of it, GI fluid loss, vomiting, diarrhea, laxative suctioning, perspiration, you lose it through perspiration, obviously. Burns is pretty serious if you have burns all over your body, and they're all producing serous or whatever exudate, and that fluid is just kind of seeping out of them all the time. You're just sort of leaking. Then you may have to replace that fluid. Hemorrhage, just bleeding, excessive diuresis, so diuretic use can cause that. Ketoacidosis can as well. Can cause fluid loss. So IV treatments or IV fluids, there are crystalloids, like I said, and colloids. Crystalloids, think salt or sugar crystals. Okay, so if you if you are thinking about, okay, wait, is a dextrose solution, is that colloidal, or is that crystal, or is that crystalloid or colloid, then you would say, well, dextrose is basically, it's glucose, D-glucose, so, and sugar forms a crystal, so therefore it's crystalloid. Okay, and then you'll never have to worry about that ever again. So used to replace fluids and promote urine output. Okay, so you're replacing fluids with either crystalloid or colloid because they're all dissolved in fluid, and promoting, which will promote urine output. Capable of leaving the plasma and moving to the interstitial spaces. So again, we have that movement. We put it into the vessel, but it's going to go hopefully where it's needed. Is the idea. So compartment entered depends on tonicity of the intravenous fluid. If you administer a hypertonic solution, okay, so if you put a hypertonic solution into the vessel, that means it's going to have more particles. Hypertonic solutions have more particles. Then that's going to draw water from the interstitial fluid. Okay. All right. So what happens to the water that's already in the body? Well, it's going to move into the vessel, or at least be held in the vessel. Okay, so this is from your book, table 25.1, and it shows some of the different solutions and tonicities. Now, normal saline, 0.9% saline, sodium chloride. And there's hypertonic, which is 3%. There are different values. This is just a list of some of these. Hypotonic is going to have less salt, less sodium chloride. And then there are things like lactated ringers, which has potassium. It also has lactate in it. So just different formulations, I guess. Same with Plasmolite. They have different molecules in them. Dextrose has this really cool thing because it's sugar. If you think about the Krebs cycle, gosh, I hate to take you back there, but if you think about the Krebs cycle, remember the Krebs cycle threw off some CO2. It also threw off some H2O. So dextrose, even though it's a particle, and dextrose just is D-glucose. Okay, it's the D enantiomer, not that important. But when you put glucose or dextrose in, then that will, when it's metabolized, it actually produces more water. Okay, so let's just stop and think about that for a second. If we give an isotonic solution, but it has dextrose, we're still very gradually going to be increasing the fluid volume. We're going to increase the water, the amount of water that's in the body overall, and that can be, a good, more delicate way of increasing fluid. The other thing is that glucose is glucose, or dextrose is glucose, and glucose is a nutrient. I mean, it's sugar. It's a good way to make ATP for energy. Okay, so that's good too. And I have here a note, plus I wrote some stuff in the comments below. Because dextrose is metabolized quickly, the solution is sometimes considered hypotonic. So even though the actual crystals, the actual particles in there are isotonic, it can be considered hypotonic. I wouldn't though. All right, so colloids. Colloids, we've been talking about colloidal pressure, and usually when we think of colloids, well, I think of albumin, I think of protein. And so colloids are typically proteins, but also starches and other polysaccharides. There are companies that produce specific colloidal type of IV treatments. But either way, they're molecules that are too large to easily cross the membrane. So that means that once they're put into, and this is the idea of them, so once they are put into the blood, they're designed to kind of stay in the blood. So a lot of times this is just like the addition of albumin. You put albumin into the blood, then that's going to either hold or pull water into the blood vessel. And so we call those plasma volume expanders. because we're putting something in that's going to, and in this case, it's not like ions, which are able to move and will redistribute over time. These are designed to kind of stay in the vessel to continue to pull fluid in. So if you do have, you know, some kind of a circulatory collapse kind of a situation where you don't have enough blood flow, then you can add these colloids, and that'll cause your blood vessels to expand. It'll pull that fluid from the interstitium and back into the vessel, so you can get the blood flowing to maybe perfuse that blood or perfuse organs in a different area. Okay, all right. So the most commonly used colloidal solution is 5% albumin, but this one, Dextran 40, is the prototype drug. So just remember that either one of these can be used. But Dextran 40, D5W, which means 5% dextrose in water, is the prototype drug. So that's the one you're going to have to really know. And this is the information for it. So mechanism of action: it raises the oncotic pressure of the blood, because that colloid, it's a type of polysaccharide, that synthetic polysaccharide that moves in, and that's just kind of where it stays. So it expands the plasma volume within minutes of administration, and its primary use is as a fluid replacement with hypovolemic shock. So that means that you don't have enough fluid in your blood vessels. This replaces the fluid, plus it pulls more in. Okay, from hemorrhage. So this could happen from hemorrhage, surgery, severe burns, things like that. Adverse effects: hypersensitivity reactions, so allergies kind of. Fluid overload, because there's too much, and hypertension. So generally it sounds like you've just it's just gone too far at that point. Okay, so you look this over, make sure you understand this particular IV compound. Okay, so electrolyte imbalances. So, but of course, not to jump back, but also make sure you understand the different tonicities and effects of like dextrose in the crystalloid as well. Okay, so all right, so electrolyte imbalances: positively or negatively charged inorganic molecules or ions. So molecules, we're talking about ions. So that's what we're talking about. Essential to nerve conduction. We've covered a lot of this in physiology. Nerve conduction, membrane permeability, water balance, other critical body functions. So we've talked about a number of these and what they do. We're in this particular section, we're going to really go over sodium and potassium. Calcium is another big one that can really have a big effect on health, and that's another one that we see imbalances of more regularly. But right now we're going to talk about potassium and sodium. So to start with sodium and water regulation. So sodium is essential for maintaining osmolality, and that's because sodium is on the outside of the cell. It is the major ion that's outside of cells and in your plasma, and it's just everywhere. As opposed to like potassium, which is mainly found inside cells. So that's its main role. Okay, so maintaining osmolality, well, I shouldn't say it's its main role, because it's also important for nerves, but in terms of water regulation, it's the osmotic balance molecule. So water balance, acid-base balance, which we'll talk more about acid-base balance in a minute. So water travels with or towards sodium. Hopefully we know that by now. Sodium movement is the link between water tension, blood volume, and blood pressure. Yes, also we've been talking about that for quite some time, especially with renal stuff. Regulated by kidneys. Aldosterone is what regulates the reabsorption of it via an exchange process with potassium in the kidneys. So hypernatremia is a sodium level above 145 milliequivalents per liter, most commonly caused by kidney disease, because that is where sodium handling takes place, is in the kidneys, mainly in the ascending and the distal distal tubule of the nephron. So with hypernatremia, sodium accumulates because you have decreased excretion, high net water loss. Okay, so if you're losing water but not sodium, then your concentration of sodium is going to be higher. High doses of corticosteroids or estrogens. Remember, corticosteroids are made by the adrenal medulla, and they include the glucocorticoids and the mineralocorticoids like aldosterone. Okay, so that's what we're talking about with corticosteroids. Sorry, corticosteroids. I learned to say that wrong, and I'm trying to correct myself. Okay, so signs and symptoms: thirst, fatigue, weakness, muscle twitching. So hopefully a lot of these make sense because it does have muscle twitching. It does have a neural component. Convulsions, altered mental state. Here we go. Neural components all over the place. Right there. Convulsions, altered mental state, decreased level of consciousness. Can be treated if you have hypernatremia. If you have a problem with that, then a lot of times you're okay just by decreasing your salt intake. Okay, so acute hypernatremia. So if it's sudden onset, rapidly progressing, then you might want to administer a hypotonic intravenous fluid. So if you're hypovolemic, you don't have enough volume. So if it's because you've lost a lot of water that your concentration of sodium is higher, then you can give a hypotonic solution, replace that water to try to match the sodium that's already in there. Or really diuretics if you have too much volume. Okay, hyponatremia, so that's below 135, caused by excessive dilution of the plasma. So now we have too much water or excess antidiuretic hormone. Something is causing you to retain too much water. Excessive administration of hypotonic IV solutions. So yeah, so vomiting, diarrhea, gastrointestinal suctioning, diuretic use can also cause this. Early symptoms: nausea, vomiting, anorexia, abdominal cramping. Okay, so these are signs that you are lacking sodium, but then, of course, then you start to have the neurological functions later. Again, hyper and hyponatremia. So confusion, lethargy, convulsions, coma, muscle twitching, tremors. Okay, so hyponatremia caused by excessive dilution, so not enough sodium. Treat with loop diuretics to cause isotonic diuresis. Okay, so that's going to reduce the volume. Okay, that's going to reduce the water volume, and the equation is going to work out such that you're going to have water loss, and hopefully the sodium that's in there, that's already in your body, will recover. Okay, if it's hyponatremia caused because you've lost sodium, then you can treat with either oral sodium chloride or IV fluids containing sodium. Okay, so normal saline or lactated ringers. Okay, so prototype drug, sodium chloride. How about that? As an electrolyte or sodium supplement to treat hyponatremia when serum levels fall below 130. Okay. Okay, so hypernatremia, pulmonary edema. All right, so potassium. So essential for proper nerve and muscle function, intracellular resting membrane potential, maintain acid-base balance. So we know about some of these nerve and muscle functions of it, but potassium is also very important for the acid-base balance, especially with like the hydrogen-potassium exchanger. There's a lot of interplay between potassium and hydrogen and bicarbonate. So it's influenced by aldosterone. Remember that exchange that takes place where sodium is reabsorbed and potassium is secreted. And imbalances can be serious or even fatal. And of course, the big problem are arrhythmias. when it comes to potassium. So hyperkalemia, potassium level above 5 milliequivalents per liter. That sounds low, but of course it's supposed to be inside cells, so it's not as high in the blood. Caused by high consumption of potassium-rich food, dietary supplements. Risk with patient taking potassium-sparing diuretics. So we're talking about hyper, we're talking about too much. Potassium-sparing diuretics, that's something you have to watch for, is increased potassium levels. Accumulates when renal disease causes decreased excretion. Most serious symptoms are dysrhythmias and heart block. Okay, big thing for potassium. Other symptoms are muscle twitching, fatigue, paresthesias, or the tingling, and so it's a neurological effect, dyspnea, cramping, diarrhea. Okay, so treatment of hyperkalemia. Well, I mean, if you have high potassium, I guess the first thing to do would be to try to restrict your dietary sources of potassium. Don't eat as much potassium. Decrease dose of potassium-sparing diuretics, if that's what's causing it. Administer glucose and insulin. That can actually help to maintain hyperkalemia. There's an interaction there as well. Administer calcium to counteract potassium toxicity on the heart. So that's not a standalone type of thing, but calcium can interfere with the potassium effects. Administer polystyrene sulfonate, so Kexalate, which will help prevent the absorption of potassium in the first place. Okay, so that's hyperkalemia. Hypokalemia, potassium level below 3.5 milliequivalents per liter, caused by high doses of loop diuretics. Okay, so loop diuretics and thiazide diuretics too can cause that. Strenuous muscle activity can cause it, severe vomiting or diarrhea. So symptoms, neurons and muscle fibers are most sensitive to potassium loss, and really, so muscle weakness, lethargy, anorexia, but really the dysrhythmias and cardiac arrest are the things that we worry about. So treatment, if it's mild, you increase dietary intake. If it's severe, you can give oral or parenteral potassium supplements. Yeah. Okay. So prototype drug, potassium chloride. And it's just an electrolyte, potassium supplement. So read about that. Adverse effects. So look that over. Okay, so acid base. Alkalosis and acidosis. We've talked about this before. It keeps coming up, obviously, because it's very important. Acidosis is excess acid below 7.35. Alkalosis is excess base above 7.45. And both symptoms, acidosis and alkalosis, are usually are both symptoms of some underlying disorder. So something else is causing that. And they can both be fatal if they're not treated. Now, we know that the body uses buffers to maintain overall pH within normal limits. However, we also know that the kidneys are regulators of bicarbonate and hydrogen, so they regulate the pH, and the lungs also regulate pH through the carbon dioxide plus water, carbonic acid, bicarbonate, hydrogen. That little equation. Okay, so kidney and lungs collaborate to remove excess metabolic acid. Okay, so acidosis can be retreated with sodium by adding sodium bicarbonate, and we'll talk about this later. But alkalosis, you can add ammonium chloride or sodium chloride, and that will fix that, or at least help correct the pH problem. Okay, causes of alkalosis and acidosis. Remember, it's respiratory or metabolic. So acidosis, hyperventilation, or hypoventilation or shallow breathing so if you hold your breath, your acidity is going to go up because your carbon dioxide levels are going to go up. So if you hold your breath, carbon dioxide levels go up, your pH drops, which is acid, acidosis. Okay, so then it's the opposite with alkalosis, hyperventilation, asthma, metabolic, lots of things. Severe diarrhea, kidney failure, diabetes, excess alcohol ingestion, starvation. And then for metabolic alkalosis, so that was metabolic acidosis, metabolic alkalosis, constipation, ingestion of excess sodium bicarbonate, diuretics that cause potassium depletion. There's that potassium. So when you lose potassium, then your pH tends to increase, and severe vomiting is another one. So acidosis, maybe respiratory causes, hypoventilation, metabolic, diarrhea. So respiratory means breathing issues. Metabolic means something else in the body. Diarrhea, kidney failure, diabetes, excess alcohol, starvation. Symptoms, lethargy, confusion, coma. Okay, so then a lot of these I realize overlap, but these are the categories. Okay, so deep, rapid respirations in an attempt to blow off excess acid. So lethargy, confusion, coma with rapid respiration. The body's response to that is going to be to get rid of the carbon dioxide as much as possible and lower that pH. Okay, the goal, of course, is to quickly reverse the effects, and a lot of times that would be the administration of sodium bicarbonate or sodium bicarbonate infusion. Okay, because that will correct the pH. So that is the prototype drug for acidosis or bicarbonate deficiency. But acidosis, you give sodium bicarbonate. Bicarbonate is a base, and that will help to tie up the excess acid or the excess hydrogen. So mechanism: decreased pH of wait a minute. Sodium bicarbonate is going to increase the pH of body fluids. Increase the pH of body fluids, decrease the amount of hydrogen. Ugh. So that should say increase. Increase the pH. Hopefully you know that, and we've all made that mistake on exams, and I mean all of us, me too. So primary use, treatment of acidosis, adverse effect, metabolic alkalosis caused by receiving too much bicarbonate ion, and hypokalemia. Okay, so this could be an adverse effect, is the loss of potassium. So yeah, when you're treating with this, of course, you're going to want to monitor the blood gas reports. Hopefully, anytime there's a pH issue, you should be doing that anyway. Use cautiously in patients with cardiac disease or renal impairment, and a lot of times this might come back to the hypokalemia, but pH in general, certain enzymes have to work at a certain pH. Okay, so there's your drug sheet on bicarbonate. Alkalosis, so now your pH is too high. Again, just like with acidosis, it could be respiratory, so it's going to be over 7.45. Maybe respiratory, so hyperventilation caused by hyperventilation. Okay, so hyperventilating is going to cause your pH to go up. Anxiety or high altitude. Maybe metabolic, prolonged constipation, excessive, so we read through these before, excessive sodium bicarbonate, diuretics that cause potassium depletion. Symptoms are due to central nervous system stimulation, nervousness, hyperactive reflexes, convulsions, slow, shallow respirations in an attempt to retain acid. We had quick with acidosis, it's going to be shallow, and remember that's an attempt to compensate. All right, so treatment, administration of ammonium chloride. Ammonium chloride has an H4, so this is actually going to contribute hydrogen ions ultimately. And administration of sodium chloride with potassium chloride. So these two also work with, so even though we think of sodium chloride as being neutral, and it is neutral, however, the interactions in the cells, in the body, will lead to a production of more acid, okay? Okay, with both potassium and really I'm kind of focusing on the chloride here. Okay, so that will lead to ultimately an increase in hydrogen, and that's a good way to do it rather than just throwing acid in somebody's body. Throw something in there that will actually cause a complementary reaction within the body to let the body produce more hydrogen. Okay, so ammonium chloride, something to remember about that. Is assess pH in arterial blood gas levels prior to administration. Yes, contraindicated in the presence of liver disease, but really here, infuse slowly to avoid ammonium toxicity and decrease irritation to veins. So that's something to keep in mind there. And I believe, yes, this is the last slide for this chapter.